Hey everyone, welcome to the Deep Dive. I'm Harvey.
And I'm Donna,
And we're both MCCQE reviewers.
here to help you
Yeah, get through.
make sense of all the material for the MCCQE.
Yeah, think of us as your guides through all this material.
Absolutely.
So for this deep dive, we're focusing on adrenal conditions.
We're going to break down all those major concepts you need to know.
And we're going to be using a really great source, Stat Pearls.
It's a really good resource for evidence-based medicine.
Yeah, we're going to cover three big ones today. Adrenal insufficiency, congenital adrenal hyperplasia, and pheochromocytoma.
Big ones, but important ones.
And just a quick reminder before we jump in, this is for educational purposes only. It's not a substitute for advice from a qualified healthcare professional.
Of course.
So let's start with adrenal insufficiency. What is it?
Adrenal insufficiency is a condition where your adrenal glands aren't producing enough of certain hormones.
Okay, so we're talking about those little glands that sit right on top of your kidneys, right?
Exactly.
What hormones are we talking about?
The main hormones are cortisol and aldosterone.
Cortisol, that's like the stress hormone, right?
Exactly. Cortisol is often called the stress hormone because it helps your body respond to, well, stress.
Okay.
But it also plays a role in regulating your metabolism, your blood sugar, and even your immune system.
Wow, so many things.
Many things.
So if you don't have enough cortisol, things can start to go a little bit haywire.
Exactly.
And then there's aldosterone.
Yes.
What's so important about that one?
Aldosterone is crucial for maintaining the right balance of electrolytes in your body, especially sodium and potassium.
Electrolytes. Those are the things we need to, like, for our nerves and our muscles to work properly.
That's right.
Okay, so adrenal insufficiency, it can present in a lot of different ways, right?
Yeah, adrenal insufficiency can be tricky because it can present in a wide spectrum of ways.
Okay.
Some people might just have mild, vague symptoms like fatigue or a bit of weight loss.
So you might not even know.
You might not even know.
You might just think you're a little run down. But in some cases, it can be much more serious.
In other cases, adrenal insufficiency can lead to a life-threatening condition called adrenal crisis.
The adrenal crisis. What happens during an adrenal crisis?
During an adrenal crisis, your body essentially goes into shock because it doesn't have enough cortisol to deal with a stressful situation.
Okay.
You might see symptoms like dangerously low blood pressure, confusion, severe abdominal pain, and even loss of consciousness.
Wow, that's scary.
It is scary.
So we really need to be able to recognize the signs and symptoms of adrenal insufficiency early on.
Exactly.
But before we get into that, I'm curious about the different types of adrenal insufficiency.
Right. There are three main types: primary, secondary, and tertiary.
Okay, so primary, secondary, tertiary. Let's start with primary. What's that?
In primary adrenal insufficiency, the problem is with the adrenal glands themselves.
So they're just not making enough hormones.
They're simply not able to produce enough hormones.
And that's most commonly caused by an autoimmune attack, right?
Right. Exactly. Where the body's own immune system mistakenly attacks the adrenal glands.
It's like your body is turning against itself.
It's like your immune system gets its wires crossed and starts seeing your adrenal glands as the enemy.
Okay.
And then there are some less common causes of primary adrenal insufficiency, like infections, certain medications, or even bleeding within the adrenal glands.
Okay, so that's primary. What about secondary?
Secondary adrenal insufficiency is when the problem lies with the pituitary gland, which is a small gland located at the base of your brain.
The pituitary gland, that's like the master gland, right?
Yeah,
It controls a lot of the other glands in our body.
It produces a hormone called ACTH, which acts like a messenger, telling the adrenal glands to produce cortisol. In secondary adrenal insufficiency, the pituitary gland isn't producing enough ACTH, so the adrenal glands don't get the signal to make cortisol.
So the adrenal glands could be totally fine.
The adrenal glands themselves might be perfectly fine, but they're not getting the instructions they need from the pituitary. And some common causes of secondary adrenal insufficiency include tumors in the pituitary gland, certain medications, or even radiation therapy to the head.
Okay, and then last but not least, tertiary adrenal insufficiency.
Tertiary adrenal insufficiency is similar to secondary, but the problem is even higher up in the chain of command.
Higher up, okay.
This time, it's the hypothalamus, a part of your brain that controls the pituitary gland that's not functioning properly.
So it's like a miscommunication.
It's like a communication breakdown between the hypothalamus, the pituitary, and the adrenal glands.
Okay, so the hypothalamus produces CRH.
It produces a hormone called CRH, which tells the pituitary gland to release ACTH.
Yeah.
In tertiary adrenal insufficiency, the hypothalamus isn't producing enough CRH, which ultimately leads to low cortisol production.
Got it. So we've got these three types.
Yes.
Primary, secondary, tertiary. How do we tell them apart?
That's a great question.
I mean, wouldn't symptoms be pretty similar?
While the symptoms of all three types can overlap, there are some subtle differences.
Okay, I'm all ears. Let's hear it.
One key difference is in the electrolyte imbalances we see.
Electrolyte imbalance.
Yes. Remember how we talked about aldosterone being important for regulating sodium and potassium?
Yes.
And those electrolyte imbalances are much more prominent in primary adrenal insufficiency?
Okay, why is that?
Because in primary adrenal insufficiency, the problem is with the adrenal glands themselves, so both cortisol and aldosterone production are affected.
Okay.
But in secondary and tertiary adrenal insufficiency, aldosterone production is often preserved
Okay.
because the renin-angiotensin system, which regulates aldosterone, is still functioning.
So the electrolyte imbalances can be a clue that we're dealing with primary adrenal insufficiency.
Exactly.
Okay, are there any other clues?
Another helpful clue is the presence or absence of hyperpigmentation.
Hyperpigmentation, that's like a darkening of the skin, right?
Exactly, especially in areas like the elbows, knees, and knuckles.
What causes that?
It's actually related to the high levels of ACTH that we see in primary adrenal insufficiency.
High ACT.
Remember, the pituitary gland is trying to stimulate the adrenal glands, but they're not responding.
Yeah.
And ACTH can actually stimulate melanocytes, the cells that produce melanin, to produce more pigment.
So it's like a side effect of the pituitary trying to work overtime.
Exactly.
Okay, so we've got the electrolyte imbalances and the hyperpigmentation.
Yes.
What else should we be looking for?
Well, apart from those specific findings, the symptoms themselves can give us some hints.
Yep.
In general, adrenal insufficiency tends to present with a combination of nonspecific symptoms like fatigue, weakness, weight loss, and decreased appetite.
Okay, but those are all pretty common symptoms. How do we know it's not just something like the flu?
You're right. Those symptoms can be caused by many other things.
Yeah.
That's why a thorough medical history is so important.
Okay.
We need to ask about things like, have they been under a lot of stress lately?
Yeah, have they had any recent infections? Are they taking any medications, especially corticosteroids, which can suppress adrenal function?
Precisely. And then, of course, we have laboratory testing to help confirm the diagnosis.
Right, like checking those cortisol and ACTH levels
Exactly.
that we talked about earlier.
We might also check electrolytes, blood sugar, and even do a special test called an ACTH stimulation test.
The ACTH stimulation test, tell me more about that.
So in the ACTH stimulation test, we give the patient an injection of synthetic ACTH and then measure their cortisol levels at specific time intervals.
Okay.
In a healthy person, cortisol levels should rise significantly in response to the ACTH.
But in someone with primary adrenal insufficiency,
Yes.
their cortisol levels wouldn't rise much.
Exactly, because their adrenal glands are damaged and can't respond to the ACTH.
Got it.
And that helps us differentiate primary adrenal insufficiency from secondary or tertiary adrenal insufficiency.
Okay, this is all starting to make sense.
Good.
Once you diagnose it, how do you actually treat adrenal insufficiency?
The cornerstone of treatment is hormone replacement therapy.
Okay, so we're giving the patient back the hormones that their adrenal glands aren't making enough of.
Exactly.
So for someone with primary adrenal insufficiency,
Yes.
where both cortisol and aldosterone are deficient,
Yes.
they would need both glucocorticoid and mineralocorticoid replacement.
That's right.
Okay.
Glucocorticoids are typically given in the form of hydrocortisone or prednisone,
Okay.
and mineralocorticoids are usually replaced with fludrocortisone.
Okay, and what about those cases of secondary or tertiary adrenal insufficiency,
Yes.
where aldosterone production is often preserved?
In those cases, they might just need glucocorticoid replacement.
Okay, so hormone replacement is key.
Yes.
Anything else that's important in managing adrenal insufficiency?
One thing that's absolutely crucial is patient education,
Okay.
especially when it comes to recognizing and managing adrenal crisis.
Right, that can be so dangerous,
Exactly.
like we talked about.
Patients need to be aware of the triggers for adrenal crisis, which can include things like illness, surgery, trauma, and even emotional stress.
Okay.
They also need to know how to adjust their medication doses during times of stress.
Okay.
And they should always carry an emergency injection of hydrocortisone with them, just in case.
It sounds like a lot of responsibility for the patient.
It is. It requires open communication,
Yeah.
careful monitoring, and a willingness to adapt the treatment plan as needed.
It's like a partnership between the doctor and the patient.
Absolutely.
Okay. Well, this has been incredibly helpful. We've covered a lot of ground on adrenal insufficiency,
Yes, we have.
from the different types to the importance of recognizing and managing adrenal crisis.
All very important topics.
But before we move on,
Yes.
I'm curious about something you mentioned earlier. You
Sure.
said that certain medications can cause primary adrenal insufficiency.
Yes.
What medications are we talking about?
One of the most common culprits is a group of antifungal medications called azoles, particularly ketoconazole.
Ketoconazole.
Okay. So if a patient is on ketoconazole long-term, we need to be on the lookout for signs of adrenal insufficiency.
Okay, what other medications can do this?
Another group to be aware of is the rifamycins, like rifampin, which are used to treat tuberculosis, and certain chemotherapy drugs like mitotane, which is used to treat adrenal cancer.
Okay, so quite a few.
Yes.
Wow, I didn't realize that.
It just goes to show how important it is to take a thorough medical history and consider all possible causes when evaluating a patient with suspected adrenal insufficiency.
That's a great point. Well, this has been a fascinating deep dive into adrenal insufficiency.
It has.
Now let's shift gears and explore another adrenal condition, congenital adrenal hyperplasia.
Sounds good to me.
Okay, what can you tell us about congenital adrenal hyperplasia?
Well, unlike adrenal insufficiency, where there's a deficiency of hormones, congenital adrenal hyperplasia, or CAH,
Okay.
is characterized by an overproduction of certain hormones, specifically androgens.
Androgens, those are the male hormones, right? Like testosterone.
Can.
And this overproduction of androgens
Yes.
can have a big impact on someone's development and health, depending on the specific type of CAH they have.
Absolutely.
So there are different types of CAH.
Yes, there are several types, each caused by a deficiency in a different enzyme involved in the production of adrenal hormones.
Enzymes, those are like those little chemical workers that help everything happen in our bodies.
Precisely.
Okay, so in CAH,
Yes.
the missing or malfunctioning enzyme disrupts the normal pathway for making cortisol and aldosterone.
That's a great way to put it.
So it's like a factory where like one of the workers is missing
Yeah,
and the whole process is thrown off.
that's a great analogy.
Because of this disruption, the adrenal glands end up producing more androgens
Yes,
instead of the usual balance of hormones.
exactly.
Okay, you mentioned different types of CAH.
Yes.
Which one is the most common?
By far, the most common type of CAH is caused by a deficiency in an enzyme called 21-hydroxylase.
21-hydroxylase. Didn't we just talk about
I
that?
get a sharp memory.
I try.
Yes, it's the same enzyme that's often targeted in autoimmune adrenal insufficiency.
So in CAH, it's not an autoimmune attack.
Right.
It's a genetic deficiency in the enzyme itself.
Exactly.
It's a genetic mutation that prevents the enzyme from working properly.
That's right.
So what happens when you have a 21-hydroxylase deficiency?
Well, because the enzyme is involved in making both cortisol and aldosterone, a deficiency can lead to a shortage of these essential hormones.
So it's almost like having a mild form of adrenal insufficiency built in.
In some cases, yes.
And some people with CAH might experience symptoms like salt wasting,
That's right.
where they lose too much sodium in their urine.
That's right. It's due to the deficiency in aldosterone, which normally helps the body retain sodium.
Okay.
Without enough aldosterone, the kidneys can't hold on to sodium, leading to excessive loss in the urine.
That makes sense. And you also mentioned an overproduction of androgens. So how does that play into all of this?
The overproduction of androgens is actually a consequence of the cortisol deficiency. Remember, the pituitary gland releases ACTH to stimulate cortisol production.
Yeah, and when there's not enough cortisol, the pituitary keeps pumping out more ACTH,
Exactly.
trying to get the adrenal glands to respond.
And all that extra ACTH doesn't just stimulate cortisol production. It also stimulates the production of androgens.
So it's like a vicious cycle.
It's like a feedback loop gone haywire. The body is desperately trying to make more cortisol, but it can't, so it ends up producing an excess of androgens instead.
Okay, and those excess androgens can have a variety of effects on the body,
Exactly.
depending on the age and sex of the individual.
Right.
So what are some of the ways that excess androgens can manifest in people with CAH?
Let's start with females.
Okay.
One of the most striking effects of excess androgens in females is the development of ambiguous genitalia.
Ambiguous genitalia, so meaning it's not clear whether the baby is male or female.
Exactly. The excess androgens can masculinize the external genitalia, making it difficult to determine the sex of the baby at birth.
Wow, that sounds like a difficult situation.
It is. It definitely is.
And it highlights the importance of early diagnosis and treatment.
Exactly.
Okay, so ambiguous genitalia is one potential effect.
Yes.
What else might we see?
In addition to the effects at birth, Girls with CAH might experience early puberty,
Early puberty,
also known as precocious puberty.
meaning they start developing secondary sexual characteristics.
Exactly, like breast development and pubic hair at a much younger age than usual.
Wow.
And they might also experience other androgen-related effects later in life, like acne, hirsutism,
Hirsutism?
which is excessive hair growth in a male pattern, and irregular periods.
Wow, so the effects can be pretty far-reaching.
They can?
What about males with CAH?
In males, the effects are a bit different, since males already have higher levels of androgens naturally.
Okay.
The excess androgens in CAH might not be as noticeable early on.
Okay.
However, they might experience precocious puberty with early development of facial and pubic hair,
Okay.
deepening of the voice, and increased muscle mass.
So it's almost like their puberty's getting fast-forwarded,
Precisely.
and they might have problems with fertility later.
They might later in life, yes, due to the hormonal imbalances caused by CAH.
Okay, this is all starting to come together.
Yeah.
We've got the different types of CAH, the underlying enzyme deficiencies,
Mm-hmm.
the various ways that excess androgens can manifest, both in females and males.
It is.
How do we actually diagnose CAH?
Early diagnosis is key.
Okay.
Thankfully, we have newborn screening programs that can detect most cases of CAH.
Newborn screening, so that's like the test they do on babies shortly after birth.
Exactly.
Right.
They take a small blood sample from the baby's heel
Uh-huh.
and test it for various markers, including one called 17-hydroxyprogesterone, or 17-OHP, which is elevated in most types of CAH.
Okay, so if the 17-OHP levels are high,
Yes,
that raises a red flag for CAH.
it does.
Okay, and then we do further testing.
If the screening test is positive, we can do further testing to confirm the diagnosis and determine the specific type of CAH. What kind of testing?
One important test is a cosintropin stimulation test.
Cosintropin stimulation test.
It's similar to the ACTH stimulation test we talked about earlier.
Okay.
We give the patient an injection of cosintropin, which is a synthetic form of ACTH,
Okay.
and then measure their hormone levels.
So looking at the pattern of hormone responses can help us figure out which enzyme is deficient.
Precisely.
And then we can also do genetic testing to confirm the diagnosis.
And provide genetic counseling to the family.
Genetic counseling, that's where a healthcare professional helps families
Yes.
understand the risks of inheriting or passing on genetic conditions.
Exactly.
Okay.
Because CAH is an inherited condition, genetic counseling can be very helpful for families in understanding the implications for their children and future pregnancies.
Okay, so we've talked about the different types of CAH, the symptoms, how it's diagnosed.
Yes.
Now, I'm curious about the treatment.
Yes.
How do we actually manage CAH?
The mainstay of treatment for CAH is hormone replacement therapy. Hormone replacement therapy.
We're essentially trying to correct the hormonal imbalances caused by the enzyme deficiency.
So for someone with a 21-hydroxylase deficiency, they would need both glucocorticoid and mineralocorticoid replacement,
That's right.
just like in primary adrenal insufficiency.
Yes, the specific doses are tailored to each individual's needs.
Okay.
And we monitor their hormone levels closely to make sure they're getting the right amount of replacement.
Makes sense.
Yes.
And what about the excess androgens?
Yes.
We do anything about that?
In some cases, we might use medications to suppress androgen production, especially in females with CAH who are experiencing virilization.
Okay.
Yes.
And what about those cases of ambiguous genitalia in females? How are those managed?
That's a complex issue, and the approach has evolved over the years.
Okay.
In the past, early surgical intervention was the norm.
So they would surgically reconstruct the genitalia to align with the assigned sex?
Yes, but there's growing recognition that early surgery can have long-term consequences, both physically and psychologically.
What kind of consequences are we talking about?
Well, some people who underwent early surgery have reported dissatisfaction with their cosmetic outcomes,
Okay.
pain during intercourse, and difficulty achieving orgasm.
Oh, wow.
There are also concerns about the potential impact on gender identity, especially when surgery is performed before a child is old enough to consent.
Right.
Yeah.
That makes sense.
Well,
So it sounds like there's a shift away from doing that early surgical intervention.
the current trend is towards a more conservative approach, delaying surgery until the child is older and can participate in the decision-making process.
Okay, so giving the child more agency
Exactly.
to make decisions about their own body.
And it's about taking a more holistic approach, considering not just the physical anatomy, but also the child's psychological well-being and gender identity.
That's really important.
It is.
This is all incredibly important information. I can see why CAH is considered a high-yield topic for the MCCQE.
Absolutely. It's a complex condition with far-reaching implications, and it really tests your understanding of adrenal physiology and endocrinology in general.
Okay, well, we've covered a lot of ground on CAH,
We have.
and I think we've done a great job of demystifying it.
I think so too.
We still have one more adrenal condition to tackle, pheochromocytoma.
Right, and this one is a real wild card.
Okay.
It has the potential to cause dramatic swings in blood pressure
Oh.
and a host of other challenging symptoms.
I'm ready for the challenge.
Okay.
What can you tell us about pheochromocytoma?
Pheochromocytoma is a rare tumor that arises from chromaffin cells.
Chromaffin cells, those are the cells in the adrenal medulla that produce catecholamines, right?
You got it.
Those are our fight-or-flight hormones.
Catecholamines are hormones like epinephrine and norepinephrine,
Adrenaline.
which are also known as adrenaline and noradrenaline.
Right, those are the ones that get our hearts racing and our blood pressure up when we're stressed out.
Exactly. And when you have a pheochromocytoma pumping out excess catecholamines,
Yeah?
it can create a whole host of problems.
What kind of problems?
Well, the most common symptom is hypertension, which can be persistent or episodic.
Episodic hypertension, meaning their blood pressure shoots up suddenly
Exactly.
and then comes back down.
And those episodes can be triggered by all sorts of things,
Okay.
like stress, exercise, certain foods, or even just changes in posture.
Wow, that sounds unpredictable
It can be.
and potentially dangerous.
It is, and the hypertension caused by pheochromocytoma can be very difficult to control with conventional medications.
Okay, so hypertension's a big one.
Yes.
What other symptoms might we see?
Other common symptoms include severe headaches, palpitations, excessive sweating, anxiety, and tremors.
So it almost sounds like a panic attack.
You're right. There can be a lot of overlap in symptoms.
Yeah.
That's why it's important to consider pheochromocytoma in the differential diagnosis for anyone presenting with these kinds of symptoms, especially if they have resistant hypertension or a family history of pheochromocytoma.
Makes sense. So let's say we suspect someone might have a pheochromocytoma. How do we go about confirming the diagnosis?
The first step is biochemical testing.
Biochemical testing.
We'll be looking for elevated levels of metanephrines and catecholamines in the blood or urine.
Metanephrines, those are metabolites of catecholamines, right?
Precisely.
Meaning it's what's left over after the body breaks down epinephrine and norepinephrine.
Exactly. And measuring metanephrines is actually a more sensitive and specific test for pheochromocytoma than measuring catecholamines directly.
So if we see elevated metanephrines, that's a pretty strong indicator.
It is.
What next?
Once we have biochemical confirmation, we'll need to locate the tumor using imaging studies.
What kind of imaging studies?
CT scans and MRIs are the most commonly used imaging modalities for visualizing pheochromocytomas.
Okay, so once we've located the tumor,
Yes.
what's the treatment?
The definitive treatment for pheochromocytoma is surgical removal of the tumor.
Surgery. Sounds pretty straightforward. Are there any special considerations?
Yes, actually, surgery for pheochromocytoma can be quite challenging.
Why is that?
That's because manipulating the tumor during surgery can cause a massive release of catecholamines.
Oh, wow. So like squeezing all the adrenaline out of there.
Exactly.
Yeah.
And that surge in catecholamines can lead to dangerous spikes in blood pressure and heart rate.
That sounds pretty risky.
It is. It's a tricky surgery.
Yeah.
That's why careful preoperative preparation is essential.
Okay.
We need to make sure the patient's blood pressure is well controlled before surgery.
Uh-huh.
And we often use alpha blockers and beta blockers to help achieve that.
Alpha blockers and beta blockers, those are medications that help lower blood pressure and heart rate.
Exactly.
So it's all about controlling those vital signs.
Yes, we need to monitor the patient very closely during and after surgery
Okay.
to make sure their blood pressure and heart rate stay within a safe range.
So surgery is not for the faint of heart.
It's not...
Okay, so surgical removal is the preferred treatment,
Yes.
but what if the tumor is inoperable?
In some cases, we might consider radiation therapy or chemotherapy to try to shrink the tumor or slow its growth.
And what about medications?
Yes.
Can those help manage the symptoms of pheochromocytoma?
Yes, we can use medications like alpha blockers and beta blockers to help control blood pressure and heart rate,
Okay.
even in cases where surgery isn't an option.
So it's really a multi-pronged approach.
Exactly. And it often requires a team of specialists, including endocrinologists, surgeons, and anesthesiologists,
Wow, a whole team.
working together to provide the best possible care.
Okay, well, this has been an eye-opening deep dive into pheochromocytoma.
It has been.
It's a rare condition,
It is.
but it's certainly one that every medical student should be familiar with.
Absolutely. It's a classic example of how a single tumor can wreak havoc on the body's delicate hormonal balance.
It really is. Well, I think we've done a great job covering the basics of pheochromocytoma.
I think so too.
But before we wrap up part one of this deep dive,
Okay.
I'm curious about something you mentioned earlier.
Right.
You said that some people with pheochromocytoma have episodic hypertension.
Yes.
What exactly triggers those sudden spikes in blood pressure?
That's a great question.
Right, try.
The triggers can vary from person to person,
Okay.
but some common culprits include stress,
Yeah, physical exertion.
certain foods or drinks that contain tyramine, which is a naturally occurring amino acid,
Okay.
and even medications like certain decongestants.
So many things.
And even simple things like bending over or changing positions can sometimes trigger a surge in catecholamines
Okay.
and send their blood pressure skyrocketing.
Wow.
Yeah,
So it's really important for these patients to be aware of their triggers and try to avoid them.
absolutely.
Okay.
And it's important for us as healthcare providers to educate patients about these triggers
Yeah.
and help them develop strategies for managing their condition.
This has been a fantastic deep dive into pheochromocytoma.
Yes.
I feel like I have a much better understanding of the condition now.
Good.
And remember, this is just the beginning.
We're just getting started.
We'll be diving deeper into some more nuanced aspects of pheochromocytoma in part 2 of this deep dive.
We will. Stay tuned.
But for now, we'll leave you with this thought-provoking question to ponder.
Okay.
Given the dramatic swings in blood pressure that we see in pheochromocytoma,
Yes.
how do we make sure these patients are safe during surgery and other procedures?
It's a good question.
Think about that and join us for part 2.
Where we'll explore the intricacies of managing pheochromocytoma in the perioperative setting.
Can't wait. See you then.
See you then. Welcome back to the deep dive.
Where we're continuing our exploration of adrenal conditions, focusing on those high-yield concepts for the MCCQE.
Absolutely. And as promised, we're going even deeper into some of the nuances that can really trip you up on the exam.
Okay, so in part 1, we talked about how adrenal insufficiency can have primary, secondary, or tertiary causes.
Right.
But those causes themselves can have different presentations.
Exactly. Like in primary adrenal insufficiency, the most common cause is autoimmune destruction of the adrenal cortex.
Right.
But even within that category, you have different types of autoimmune conditions that can lead to adrenal insufficiency.
So that's not just a one-size-fits-all diagnosis.
It's not.
We need to think about the specific autoimmune process
Exactly.
that might be at play.
For example, there's something called autoimmune polyglandular syndrome, or APS. It's a bit of a mouthful, but it basically means that the immune system is attacking multiple endocrine glands, not just the adrenal glands.
So someone with APS might have a combination of endocrine problems,
They might.
like hypothyroidism, hypoparathyroidism, and of course, adrenal insufficiency,
Exactly.
all at the same time.
And it often affects women more than men.
But then you also have isolated adrenal insufficiency.
Yes, where the autoimmune attack is specifically targeting the adrenal glands.
So in that case, it's like the immune system is just focused on those adrenal glands. That's a good way to put it.
And this one tends to affect men more often.
It does, in the first couple of decades of life.
Okay.
But then it flips, and women are more commonly affected after that.
Interesting.
Yeah.
So knowing those subtle differences in presentation,
Yes.
who's more likely to be affected at what age,
Right.
whether other endocrine glands are involved,
Yes.
that can really help us narrow down the potential causes
Absolutely.
and make a more accurate diagnosis.
It's all about piecing together those subtle clues to get to the root of the problem.
Okay. This is making me think back to those lab findings we talked about earlier.
Okay.
You mentioned hyponatremia and hyperkalemia being common in primary adrenal insufficiency.
Right, and those electrolyte imbalances are directly related to the deficiency in aldosterone.
Okay.
Remember, aldosterone normally acts on the kidneys to help the body retain sodium and excrete potassium.
So when aldosterone is low,
Yes.
you lose sodium in the urine and you retain potassium in the blood.
Precisely.
Okay, and this can lead to a whole cascade of problems.
From dehydration
Please.
to potentially life-threatening cardiac arrhythmias?
Exactly. It's one of those things that seems subtle at first,
Yeah.
but it can have serious consequences if it's not addressed.
Now, you also mentioned hypoglycemia
Yes.
being a potential finding, particularly in secondary adrenal insufficiency. Why is that?
That's a great question. Remember how we talked about cortisol playing a role in regulating blood sugar?
Yes.
Well, when cortisol levels are low, the body has a harder time maintaining stable blood glucose levels.
So it's almost like the body's backup generator for glucose production is offline.
That's a perfect analogy.
Yeah.
And this can lead to hypoglycemia, especially during periods of fasting or stress, when the body needs that extra boost of glucose.
Okay, so we've got electrolyte imbalances,
Yes.
potential hypoglycemia,
Yes.
and of course, those hallmark low cortisol levels.
Right.
It seems like there are a lot of moving parts when it comes to diagnosing adrenal insufficiency.
There are, and it's not always straightforward.
It's
Sometimes the lab findings can be a bit ambiguous,
okay.
and we really need to consider the whole clinical picture to make the right call.
So it's not just about memorizing those lab values.
Oh, it's not.
It's about understanding how they fit into the bigger picture of the patient's presentation.
Exactly. It's about thinking critically and
Yeah.
using those lab values as clues, not just as definitive answers.
That's a great point. Now, one crucial aspect of managing adrenal insufficiency that we touched on briefly in part 1
Yes.
is the concept of stress dosing.
Yes.
Can you elaborate on that a little bit more?
Absolutely. Stress dosing is one of those things that's so important for patients with adrenal insufficiency
Okay.
because their bodies can't mount a normal stress response when they get sick or experience trauma.
Right. So normally when we're under stress,
Mhm.
our bodies release extra cortisol to help us cope.
Exactly.
But in adrenal insufficiency,
Yes.
that doesn't happen,
Right.
which can be really dangerous.
It can. Without that surge of cortisol, their blood pressure can plummet and they can go into adrenal crisis.
So stress dosing is basically giving them extra glucocorticoids to compensate for what their body can't produce on its own.
Precisely. It's like giving their adrenal glands a little extra help when they need it most.
Okay, so when should we be thinking about stress dosing? What kind of situations warrant it?
Pretty much any situation that would put extra stress on the body can trigger a need for stress dosing.
Okay.
Think about things like infections,
That's very-
injuries.
Even intense emotional stress.
Exactly. And it's not just about major life events.
Right.
Even something as simple as a bad cold can sometimes warrant a temporary increase in glucocorticoid dose.
So patients with adrenal insufficiency really need to be tuned into their bodies
They do.
and know when to adjust their medication.
And it's crucial for us as healthcare providers to make sure they understand the importance of stress dosing and how to do it properly.
Okay, so stress dosing.
Yes.
Definitely a high-yield concept for adrenal insufficiency.
It is.
Now let's switch gears again
Okay.
and talk about congenital adrenal hyperplasia.
Sounds good.
One thing we didn't cover in part 1 is the different forms of CAH
Right.
based on those specific enzyme deficiencies.
Right. 21-hydroxylase deficiency is the most common, but there are others, each with their own unique characteristics that you'll need to know for the MCCQE.
Okay, I'm ready. Bring on those enzyme deficiencies.
All right, let's start with 11-beta-hydroxylase deficiency.
Okay.
This one is interesting because, unlike most other forms of CAH, it can actually lead to hypertension instead of salt wasting.
Wait, hypertension, that seems kind of counterintuitive.
It does.
I thought CAH was all about low cortisol and aldosterone, which would normally lower blood pressure.
You're right, it does seem counterintuitive.
Yeah.
But here's the key. In 11-beta-hydroxylase deficiency, the enzyme blockage causes a buildup of a precursor molecule called 11-deoxycorticosterone.
11-deoxycorticosterone. Okay, what's so special about that?
Well, it actually has some mineralocorticoid activity.
Okay.
In other words, it can act like aldosterone and cause the body to retain sodium and water, which ultimately leads to an increase in blood pressure. Ah, so it's like a backdoor pathway to hypertension.
Exactly.
The body can't make enough aldosterone,
Right.
but this 11-deoxycorticosterone steps in and takes over.
It causes problems.
But not in the way we would expect.
Precisely. It's a fascinating example of how a single enzyme deficiency can have such diverse effects on the body.
Okay, so 11-beta-hydroxylase deficiency.
Yes.
Definitely one to remember.
It is.
What other enzyme deficiencies should we be aware of?
Another important one is 3-beta-hydroxysteroid dehydrogenase deficiency.
Okay.
This one is particularly challenging because it can cause ambiguous genitalia in both males and females.
Wow, both males and females.
Yeah.
Why does it affect both sexes?
It's because the 3-beta-hydroxysteroid dehydrogenase enzyme is involved in the production of all three major types of adrenal hormones: glucocorticoids, mineralocorticoids, and sex steroids.
So a deficiency in this enzyme is like a triple whammy.
It is.
It disrupts the production of all the essential adrenal hormones? Exactly, and that's why it can lead to a wide range of symptoms, from salt wasting and hypoglycemia to ambiguous genitalia and other developmental abnormalities.
3-beta-hydroxysteroid dehydrogenase deficiency.
Yes,
Definitely another high-yield topic for the MCCQE.
absolutely.
It sounds like it can really throw a wrench in the works
It does.
when it comes to adrenal function.
It really highlights the importance of understanding those enzyme pathways,
Yeah.
how they can be disrupted.
This is making me realize how interconnected everything is in the endocrine system.
It is.
It's like a delicate web,
It is.
and if you tug on one thread, it can have ripple effects throughout the whole system.
That's a great observation. The endocrine system is all about balance and feedback loops, and when one part of the system is out of whack, it can affect everything else.
Okay, so we've talked about the different types of CAH and those enzyme deficiencies.
Yes.
What about genetic counseling?
Yes.
I remember you mentioned that it's an important part of managing CAH.
It is, because CAH is an autosomal recessive disorder. Okay. It's essential for families to understand the risks of passing the gene on to their children.
Right. Autosomal recessive means that both parents need to carry the gene for the condition for their child to be affected.
Exactly. And if both parents are carriers, there's a 25% chance with each pregnancy that their child will be affected by CAH.
So genetic counseling is all about helping families understand those risks
It is.
and make informed decisions about family planning.
Exactly. Genetic counselors can discuss testing options, provide information about prenatal diagnosis, and connect families with support groups and other resources.
It's all about empowering families with knowledge
It is.
and helping them navigate those complex decisions.
Absolutely. It's a crucial part of providing comprehensive care for families affected by CAH.
Now let's turn our attention back to pheochromocytoma.
Okay.
One thing that really struck me in part 1
Yes.
was the connection between pheochromocytoma and other genetic syndromes.
Right. We talked about a few of them. Von Hippel-Lindau disease, multiple endocrine neoplasia type 2, and neurofibromatosis type 1. Right.
But those are just a few examples.
Okay, so there are other genetic syndromes out there that can increase someone's risk of developing pheochromocytoma.
Exactly, and one group that's increasingly being recognized is those with mutations in genes involved in the succinate dehydrogenase complex, or SDH. The SDH complex, that rings a bell. It's involved in cellular respiration, right?
You got it.
The process that cells use to produce energy.
And mutations in these SDH genes can disrupt that process and increase the risk of developing certain types of tumors, including pheochromocytoma.
So it's another example of how seemingly unrelated cellular processes can be interconnected.
They are.
And have unexpected consequences.
Exactly. And it highlights the importance of taking a thorough family history when evaluating someone with suspected pheochromocytoma.
Okay, so if we have someone with resistant hypertension, headaches, sweating, those kinds of symptoms.
Yes.
And they also have a family history of pheochromocytoma.
Yes.
Or one of these genetic syndromes.
It's a huge red flag.
Yeah.
Absolutely. And in those cases, genetic testing might be warranted to see if there's an underlying genetic predisposition.
And if a genetic mutation is identified, it's important to screen family members.
It is.
Who might also be at risk.
Exactly. It's all about early detection and prevention.
Okay, now let's talk about some of the challenges in diagnosing pheochromocytoma.
Very.
You mentioned that the symptoms can be really varied and nonspecific.
They can.
Which can make it tricky to pinpoint.
It can. Some patients present with those classic paroxysmal attacks.
Yeah.
Sudden dramatic spikes in blood pressure, pounding headaches, drenching sweats.
Yeah.
It's like their body's fight or flight response is stuck on overdrive.
So in those cases, the diagnosis might be pretty clear-cut.
It might be, but what about those who don't have those dramatic attacks?
What about those people?
That's where it gets trickier. Some people just have persistent hypertension that's difficult to control with medications.
Okay.
And others might not even have hypertension as their main symptom.
Really? What other symptoms might they have?
They might experience palpitations, anxiety, unexplained weight loss, or even just a general feeling of being unwell.
Wow, so it can look like a lot of different things.
It can. It's a real chameleon of a condition. It can mimic so many other things.
Exactly, and that's why it's so important to keep pheochromocytoma on your differential.
Yes.
Especially for those who have resistant hypertension or a family history of the condition.
It is.
Okay, so let's say we're thinking about pheochromocytoma as a possibility.
Yes.
We've talked about those biochemical tests,
right,
measuring metanephrines and catecholamines.
Yes.
But you mentioned those tests can be a little bit tricky to interpret.
They can.
Why is that?
Well, the results can be affected by a variety of factors, including medications the patient is taking, their diet, and even their stress levels.
Okay, so we need to take all of that into account when we're looking at the results.
Exactly. And sometimes repeat testing might be necessary to get a clearer picture. It's not always a cut and dry diagnosis.
It's not.
No.
So it's another case of needing to use those lab values as clues.
It is.
Not as like the definitive answer.
Exactly. It's all about thinking critically and considering the whole clinical picture.
Okay, this has been a fantastic deep dive.
It has.
Into the nuances of adrenal insufficiency.
Yes.
Congenital adrenal hyperplasia, and pheochromocytoma.
Lots of information.
We've covered a lot of ground, from those tricky enzyme deficiencies to the challenges of diagnosing pheochromocytoma.
It's complicated stuff.
And I think we've done a great job of highlighting some of those key concepts
I think so, too.
that you'll need to know for the MCCQE.
Yes.
But before we move on to part 3, where we'll be exploring even more advanced concepts,
Even more.
I want to leave you with a question to ponder.
Okay.
Given the complexities we've discussed,
Yeah.
how might we improve our approach to screening for adrenal disorders, especially in those who present with atypical or subtle symptoms?
That's a great question.
Think about that. And join us for part 3.
We'll see you then.
Welcome back to the final part of our adrenal conditions deep dive.
We've covered a lot of ground, from the different types of adrenal insufficiency to those intricate enzyme deficiencies in CAH and the challenges of pheochromocytoma.
I feel like we've really dug deep into the physiology,
Absolutely.
the lab findings, the diagnostic dilemmas,
All those high-yield concepts you need to know for the MCCQE.
but we're not done yet.
Nope.
There are still a few more fascinating nuggets to unearth.
There are.
Okay, I'm ready for more.
All right.
Where do we go from here?
Let's circle back to adrenal insufficiency for a moment.
Okay.
We've talked extensively about the physical aspects of the condition, the hormonal imbalances, the electrolyte disturbances, the risk of adrenal crisis.
Right, but medicine is more than just the physical.
It
It's
is.
also about the mental and emotional well-being of our patients.
Exactly. And that brings us to an important aspect of adrenal insufficiency that we haven't touched on yet. The psychological impact of living with this chronic condition.
Yeah. I can imagine it can be quite a burden for patients, constantly having to think about their medication, their stress levels, the potential for a crisis.
It is a lot to carry.
Yeah.
Imagine having to meticulously plan your day around medication schedules, worrying about whether a minor cold could escalate into something more serious.
Right.
Always having to have that emergency injection on hand just in case.
It's like living with this constant low-grade anxiety.
It is, and that's why it's so important to address the psychological aspects of adrenal insufficiency, not just the physical ones.
So what can we do to help these patients cope with the emotional burden of their condition?
Well, first and foremost, I think we need to create a space for open communication. Patients need to feel comfortable talking to us about their fears and concerns.
Yeah, it's about validating their experiences and letting them know that they're not alone in this.
Exactly. And beyond that, we can connect them with resources like support groups or mental health professionals who specialize in chronic illness.
Support groups can be so helpful for patients to connect with others who understand what they're going through.
Absolutely. It's about fostering a sense of community and shared experience.
Yeah,
And sometimes just knowing that you're not alone in your struggles can make a world of difference.
right. Okay, so addressing the psychological impact of adrenal insufficiency, definitely a crucial part of holistic patient care.
Absolutely.
Now let's switch gears to congenital adrenal hyperplasia.
Okay.
I remember we touched on the management of ambiguous genitalia in females
Right.
and how the approach has been evolving.
It has. It's a complex and sensitive issue, and there's no easy answer.
There's not.
The traditional approach was early surgical intervention.
Right, to reconstruct the genitalia to align with the assigned sex.
But as we discussed, there are growing concerns about the long-term consequences of early surgery.
Yeah, what kind of consequences are we talking about?
Some individuals who underwent early surgery have reported dissatisfaction with the cosmetic outcomes, pain during intercourse, and difficulty achieving orgasm.
Wow, those are pretty significant concerns, and I imagine there are psychological ramifications as well.
Absolutely, especially when the surgery is performed before a child is old enough to consent. There are concerns about the potential impact on gender identity and the feeling of having one's bodily autonomy violated.
Yeah, that makes sense.
It does.
So it's clear that early surgery is not a decision to be taken lightly.
It's not.
And that's why there's this growing movement towards a more conservative approach,
Yes.
delaying surgery until the child is older
Yes.
and can participate in the decision-making process.
Absolutely.
So it's really about shifting the focus from what we as healthcare providers think is best
Yeah.
to what the individual, as they grow and develop their own sense of self,
Right.
feels is right for them.
Exactly. It's about respecting their autonomy and giving them a voice in their own care.
I think that's so important.
It is.
So we're really seeing this shift in the paradigm when it comes to managing ambiguous genitalia in CAH, moving away from that one-size-fits-all approach
Yeah.
towards a more individualized, patient-centered model of care.
It requires open and honest communication between healthcare providers, patients, and families, navigating these complex decisions together with empathy and understanding.
Well said. Now let's move on to pheochromocytoma.
Okay.
We talked about how surgery is the definitive treatment,
It is.
but it can be quite a risky procedure due to the potential for those catecholamine surges.
It can. Those catecholamine surges can be incredibly dangerous,
Yeah.
leading to sky-high blood pressure, rapid heart rates, and even life-threatening arrhythmias.
So how do we make sure these patients are as safe as possible during surgery?
It all comes down to meticulous planning and teamwork.
Okay.
We need a skilled surgical team, an experienced anesthesiologist, and a well-coordinated plan to manage those hemodynamic fluctuations.
Hemodynamic fluctuations. That's just a fancy way of saying changes in blood pressure and heart rate.
It is, but we need to anticipate those fluctuations and be ready to act quickly to keep the patient stable.
So what does that look like in practice?
Before surgery, we'll start the patient on alpha blockers and beta blockers.
Right, to help control their blood pressure and heart rate.
Exactly. Those medications help block the effects of those excess catecholamines.
Okay.
And then during surgery, we monitor the patient's vital signs very closely, and we have medications on hand to adjust their blood pressure and heart rate as needed.
So it's like this constant balancing act,
It is.
trying to stay one step ahead of those catecholamine surges.
Trying to keep them stable.
And even after surgery, we need to monitor them closely in the ICU
We do.
to make sure they remain stable.
Yes,
Okay, so it's a high-stakes procedure.
it
It
is.
requires a lot of expertise and vigilance.
It does.
But what about long-term? Is there a risk of recurrence after the tumor is removed?
There is, unfortunately.
Okay.
The risk of recurrence depends on a few factors,
Okay.
including the type of pheochromocytoma, whether it's part of a genetic syndrome, and whether there were any signs of malignancy in the tumor itself.
So some patients might need long-term monitoring and make sure the tumor doesn't come back.
Exactly. We might follow them with regular biochemical testing and imaging studies to catch any recurrences early.
Okay, so even after surgery, it's not necessarily over.
Not necessarily.
We need to stay vigilant
Absolutely.
and be on the lookout for any signs of trouble.
It's about taking a long-term perspective and providing ongoing care to these patients.
Okay, this has been an incredible deep dive into adrenal conditions.
It has been.
We've covered so much, from the basics to some really advanced concepts.
this info.
And I think we've done a great job highlighting those key takeaways
Definitely.
for those of you preparing for the MCCQE.
Yes.
But remember, this is just a starting point.
Absolutely.
The world of medicine is vast and ever-evolving. New research is emerging all the time, and our understanding of these conditions is constantly growing.
Keep learning.
So keep learning, keep questioning, keep that curiosity alive is what makes medicine so fascinating.
And reward.
And on that note, we'll wrap up this deep dive on adrenal conditions. We hope you found it informative and engaging.
We did too.
Until next time, keep diving deep.
See you next time.